Providing care for patients with COVID-19, brought to you by your Northeast Methodist Clinical Education Team. COVID-19 induced acute respiratory distress syndrome, also known as ARDS. ARDS patients present with severe respiratory distress, restlessness, fatigue, tachypnea, deteriorate very quickly, and are unable to keep their O2 sats greater than 88%. Patients with COVID-19 often have a change in respiratory status, along with hypoxia, increased or decreased respiratory rates, use of accessory muscles, adventitious lung sounds such as crackles or decreased breath sounds, decreased mental status. They're often confused, lethargic, and combative due to the lack of oxygen. Some tests that you may see that are very common in your COVID order sets will be a COVID PCR, rapid testing in batch orders, chest x-ray, baseline EKG, and these are some baseline laboratory values you will be collecting and trending throughout your patient's day. Some common treatments that you'll be seeing throughout your patient's day will be early proning. It's very, very important to initiate early proning. Goal FiO2 is less than 75%. Make sure the head of bed is elevated. Depending on your patient's oxygen needs, you may see high flow nasal cannula being used, Bipap or CPAP, or possibly mechanical ventilation. Some medications that are often ordered for COVID-19 patients are systemic corticosteroids for 10 days, remdesivir for 5 days, and your patient has to meet certain criteria in order to get that medication. Their O2 sats have to be less than 94% on room air. Convalescent plasma is now only used for immunocompromised patients. We do have to monitor fluid management very closely on our patients. We don't want to fluid overload them, and if we do, they're going to need diuretics. We also use bronchodilators if needed, severe bronchospasms or bronchoconstrictions only. If those medications are not effective, then we will discontinue them as soon as we determine that they're not effective.
Let's talk about the role of awake proning in the patient with COVID. Well, we have known for many years now that proning patients with ARDS in the ICU is beneficial because it increases oxygen saturation. The research on the benefits of awake proning is still mixed. Some studies show the benefits of awake proning were limited to the time patients were in the prone position and subsequently decreased when the patients returned to the supine position. Other studies support routine awake proning as it showed it decreased treatment failures and the need for intubation. Proning for the awake patient should be approached as a preventive intervention. Proning as a rescue measure, it is not recommended. Patients who meet the criteria should be encouraged to spend most of their time in the prone position, alternating laying on each side and sitting up at a 30 to 60 degree position as tolerated. If there are any concerns about the safety of the patient, the physician should be consulted for advice. Patients using high flow nasal cannula or BiPAP can also be encouraged to lay down prone if they can tolerate it. The respiratory team can assist and provide guidance as needed. There are a few important things to remember with awake proning. All extremities should be in a neutral position, avoiding hyperextension. It is also important to provide padding of soft tissues that are prone to pressure injuries. Providing extra support under the legs can decrease strain on the patient's back and increase overall comfort and the likelihood that patients will tolerate the position for extended periods of time. Lastly, remember to manage pain as necessary. Let's talk about contraindications. Inability to independently position, respiratory rate greater than 35, accessory muscle use with the work of breathing, recent nausea, vomiting, delirium, spinal instability, facial or pelvic fracture, hemodynamically unstable, and also important to know that patients that have nerve injury should be considered for a consultation with a physician before approaching the prone position. Once the patient has been proned, assessment of the initial proning position and how the patient tolerates this procedure during the first 15 minutes is quite important. The use of continuous pulse oximetry when available is recommended. EKG leads can remain anterior but off the pressure points. They can also be moved to the back if necessary. Some of the elements to document for the proning position is the patient's oxygen saturation, the oxygen device and the liters being used, the respiratory rate, if there is any dyspnea, and the amount of time the patient was in the prone position.
For additional proning documentation tips, please visit IT Helps Me or HCIS MediTips, found on My MHS Central. Discharge teaching for COVID-19 patients include hand hygiene, discuss worsening symptoms, ensure patient is isolating at home, not sharing any food, drinks, or personal items like towels and bedding, and when to stop isolating. Next, we're going to discuss oxygen delivery devices, starring our very own Robert from Respiratory Therapy.
Hello, my name is Robert. I'm one of the respiratory therapists here at Northeast Methodist Hospital. Today I'll be going over some oxygen devices, how to use them, what are the proper flow settings to use them at, FiO2 settings and details on them, and also I'll be going over some ventilator information, Bipap information, and as well as high flow information as well. First off, we'll start off with the nasal cannula. The nasal cannula everyone's pretty familiar with and common with to use. It's a device that we can help patients oxygenate. The recommended flow on this is 1 to 6 liters. Anything higher than that, we definitely want to notify the doctor if we need to increase the flow. Okay, 1 to 6 liters on the nasal cannula. Anything higher, we definitely want to notify the doctor in case we need to give them more oxygen or increase their FiO2 consumption. This can be equipped with a bubble humidifier, which gives comfort to the patient to help with any dryness in the nose and to give them a soothing comfort when they have this in place. Now, if a patient is needing more oxygen and they're needing more FiO2 concentration, we tend to jump to the next step up, which is the non-rebreather mask. And the non-rebreather mask is a reservoir bag here that provides up to 100% oxygen concentration at 15 liters flow rate on the flow meter. Now, to properly use this, we want to place the finger right here where the little valve is. Keep it occluded and let the bag inflate. Once we have full inflation of the bag, we're able to place this on the patient and help the patient with their oxygen needs. This device has to be at 15 liters for it to work and to provide the optimal FiO2 needed. Now, we do have some devices that are in between those. Instead of jumping from 6 liters to 100% non-rebreather, we have what we call here is a Venti mask. Now, the Venti mask comes in a little bag of assorted colors here, and it has this long corrugated tubing here. The purpose of all these colors here is that each one has a designated FiO2 at a designated flow rate. We have different colors and they are imprinted on the actual little device, how much flow rate to put it at, and at the FiO2 concentration it will give it. It's very easy to set up. It will come assorted in the little packet. But this device here, it'll come with the mask. You have your corrugated tubing. Corrugated tubing connects to the mask here. Then you have your desired FiO2 chamber here, connected at the distal end of the corrugated tubing. Plastic to help with the entrainment. And then the nasal cannula extension for it. This is the 50% entrainment here, which will be at 15 liters, but you have as low as 28%, and the lowest flow rate on that will be about anywhere from 5 liters to 8 liters. Then we have here is the Oximizer. It's one of our devices that we use. It's a nasal entrainment also. This little pendant right here will help entrain oxygen. Every time the patient breathes in, they get a good dose of oxygen concentration. Picture a non-rebreather that is nicely compressed in this little plastic circle here. The tubing is much more thicker to provide more flow to help with any tachypnic issues. The liter flow on this can go as low as 4 liters and can go as high as 15 liters on the flow rate. Now, it is FiO2 dependent. There is no set FiO2. If putting it at 10 liters will give you 60% FiO2, or 8 liters giving you 45% FiO2, or so forth. But you can work with the flow rate here. So if a patient is desatting, they're at 88% on 8 liters per minute on the flow rate, you can increase that to anywhere from 10 to 12, or even max them out to 15 liters to help with their oxygen needs. But this device here is a reservoir holder in here, and anytime that they can breathe in, they're able to get a good dose of oxygen from here. And again, that liter flow is from 8 to 15 liters per minute. Some do nots with this is we don't want to humidify this, because tendency to humidify will fill this little pendant right here with fluid, and it will cause some discomfort for the patient. Anytime they inhale, they will get some water in their nose. So this device should not be on a bubble humidifier, as well as the non-rebreather and the Venturi Mask. The only device that should be on a bubble to help with comfort for a patient is the nasal cannula. Okay, that's all I have for oxygen devices.
So the following oxygen devices listed on this screen were mentioned in the previous video. To summarize, a nasal cannula may be humidified. It's used to maintain O2 sats greater than 88% with a maximum flow of 6 liters. A Venturi Mask is used for a variation of liters of O2 from 6 to 15 liters, 28% to 50%. And it's also used to maintain O2 sats greater than 88%. The Oximizer can be used for 4 to 15 liters. FiO2 is dependent on the liters delivered. It's also used to maintain a O2 sat greater than 88%, and humidification is contraindicated. A non-rebreather is used for 10 to 15 liters, delivers 100% FiO2 to maintain O2 sats greater than 88%, and humidification is contraindicated.
We will be talking about the high flow nasal cannula, the Bipap, and also the ventilator that we have. First off, we'll start off with the high flow nasal cannula. So it is a high flow device that can go up to 100% FiO2 to help with flow demands, the patient's needs for flow, and also oxygenation. Now, this device does not help with ventilation, but it does help with oxygenation in case the patient is hypoxemic or needing that extra boost of oxygen to help with their oxygen saturations. The way this device works is that we have a flow rate here. We have a flow right here that can go as high as 60 liters of 60 liters per minute here. Now we do have it maxed out. The cannula is much more bigger, and also it can be equipped with humidity to help with comfort. As you can hear, the flow is much more louder, and we can go as low as 10 liters here, where it's much more subtle. The concentration on this, we can go as high as 100%, like I said, as the device shows. And then we can go as low as room air, 21%. Now, when adjusting the high flow here, we definitely want to be courteous. When we increase flow, it will alter our FiO2. And that's because it has a blender mechanism in there to help balance out, and we'll need to be adjusting every time when we make some changes on this. We decrease the flow, we have to adjust the FiO2. we increase the flow, we also want to adjust the FiO2. But the purpose of this is to help patients that are needing that extra oxygen. If a non-rebreather is not helping a patient at 15 liters, at 100% on a non-rebreather, and they're not able to fully sat above 90%, we first want to notify the doctor, and also want to see if high flow oxygenation will be beneficial for them.
High flow nasal cannula was discussed on the previous screen. Indications are for O2 sats less than 92% with a nasal cannula, or non-rebreather Oximizer at 15 liters. Contraindications for patients with apnea, unable to maintain oxygenation or ventilation while receiving high flow nasal cannula, or patients that are at high risk for aspiration. If a patient is on a high flow nasal cannula and oxygen is still not adequate, you can add a non-rebreather on top of the high flow nasal cannula at 15 liters.
Next we have is our BiPAP. We have our BiPAP here, and our BiPAP is a method here that will help with our oxygenation and ventilation. This is a good machine to use if a patient is very tachypnic, needing higher oxygen saturations, and their work of breathing is really high. So what we have here, we got most common setting that we use in the hospital here. We have the BiPAP setting here. It's a spontaneous breathing mode that the patient is able to breathe. They do not have to be sedated, but it will definitely help with their oxygen and ventilation needs. We have a couple of settings here that display an IPAP, an EPAP, a rate, FiO2, I time, rise time, and this right here is what we call is our rise time to help gradually increase those pressures in case the patient is having discomfort right from the start getting these pressures. We can actually ramp up to that set pressure. So we'll first discuss on the IPAP here. IPAP is the inspiratory positive airway pressure. Think of CPAP. CPAP is a nice continuous pressure that gives the patient. That's what IPAP is. It's going to be a set pressure that the patient is going to receive at a constant positive airway pressure. We do have an EPAP. Now EPAP is the PEEP when it comes to BiPAP. That is the expiratory pressure that will keep the lungs inflated and keep a little bit of pressure to keep them distended and helping with oxygenation. We do have a backup rate. Now this rate is not like a ventilator. When we set a rate on this machine, the patient will not be getting that set rate on this machine. In case the patient is breathing less than the set rate, that's when the backup rate will kick in. If the patient is breathing 16 breaths per minute and the set rate's at 12, the backup rate is ineffective. Unless the patient is breathing less than that rate, the backup rate will kick in for the patient. And we also have O2, which is our oxygen concentration. That is the amount of FiO2 that we can deliver for the patient. Now, as you notice, we have a test lung attached to it, but we do have, notice that we have the corrugated tubing, it's one single tube, and we have a little bit of pressure, a little bit of air that is leaking out of here. This is important to keep open. We do not want to occlude it because that will be bad for the patient. They will accumulate CO2 because this is their exhalation port. Anytime the patient is able to breathe out, this is the air where it gets excreted, okay? So we definitely don't want to keep this occluded. We want to hear this little bit of pressure coming out of the circuit, okay? We also have the heater attached to it, which gives humidification for the patient for comfort, for not delivering cold air, and drying up the mucous membranes there in the airways. A couple of important things here is that if the patient is still tachypnic on the BiPAP and they're unable to get stable while getting ventilation help, chances are they may need a higher intervention like a ventilator. What we have up here is what the patient is actually doing. The patient, we do have a rate which gives us an indication how fast the patient is breathing, whether they're breathing 18 breaths per minute, 21, or if they're very asleep and they're breathing the set rate that is set here. We have VT, which stands for tidal volume. Tidal volume gives us how much tidal volume they are actually getting in And we want to be sure that the patient's getting adequate tidal volumes to help with their ventilation. If they're having hypercapnic issues, having increased CO2 levels on their blood gases, we definitely want to be sure that they are getting the right amount of tidal volume, higher than 200 for sure. We have a minute ventilation, and we have a positive inspiratory pressure, which is our PIP pressures. A couple things down here is that the most important is our leak here. Out of these three, we want to say that the patient leak gives us information on if the mask is nice and sealed onto the patient. If the mask tend to go off to the side, a lot of that air is going to be leaking, and it'll get recorded here. We want to have a leak less than 50, which will give us a good seal, but not too tight on the patient, where we can cause some skin breakdown around the nasal and mouth area. So anything less than 50 is good. Anything higher, we definitely want to call RT to adjust the mask, or if we're able to adjust the mask, if they happen to come off it, we can simply put it back on, and to make sure that the leak is definitely less than 50.
A common question nurses have is, how can I tell my patient is not tolerating the BiPAP? If your patient's O2 sat is less than 88% on 60% FiO2 despite PEEP adjustments, their respiratory rate is greater than 30, your patient's work of breathing does not align with the ventilation cycle, and their heart rate is increased, your patient is not tolerating the BiPAP. As discussed previously in the video, there are some alarms and troubleshooting that can be fixed by nurses while they're on a BiPAP. If your leak is less than 50, adjust your face mask, make sure you have a good seal, and check your temperature port. If you're getting an alarm for insufficient pressure, check your pressure line. And if your tidal volume is less than 200, check the connections and call RT. If your patient has a decline in respiratory status, notify the MD, initiate a rapid response, ensure your patient is NPO, and anticipate intubation.
Now we have our ventilator. The ventilator will be our last resort as far as if the BiPAP is not helping, they're not meeting oxygen needs, or they're unstable on the BiPAP and still remains tachypnic, greater than 35 breaths per minute or so, intercostal breathing, abdominal retractions. This is something that we want to take over for the patient and actually help breathe for them. Okay, so we have a couple of things that I'll be discussing here. First off, we'll discuss the outside of the ventilator. We do have two circuits attached to it. We have an inspiratory and expiratory circuits here. Air tidal volume is then come out from the ventilator, from the inspiratory side, gets nice and warmed up, gets delivered to the patient, and then comes back out, and then the ventilator gets read and gives us these nice values that the patient is due. When it comes to settings on the ventilator, we have our mode that's right here on the lower left-hand side. We have our oxygen, our FiO2 concentration. We have our tidal volume. We have a rate, and we have an eye time and a PEEP as well. The most important things when it comes to a nursing standpoint is when we're relaying information, if the patient needs to get upgraded, they need to transfer to a PCU side or to an ICU side, the most pertinent information that we want to deliver is the mode that the patient is in, the amount of concentration that the patient is getting, how much volume they are getting, the set rate that they are breathing at, and the amount of PEEP that they're receiving. Those are the most pertinent information that we want to give off on report when it comes to upgrading a patient's care. Now, the mode that we're in is AC PRVC. It's the most common mode that we are using here at Northeast Methodist, but chances are, if you're ever depending on other facilities or so, you may see this most common, ACVC, which is assist control volume control. At 100%, the ventilator is doing all the work for the patient and is giving that set rate, that set tidal volume, and the amount of oxygen that they're needing. We have the oxygen concentration, which displays how much FiO2 we want to give. The oxygen concentration goes as high as 100% and goes as low as 21%, room air. The tidal volume is the amount of volume delivered to the patient, which we want to be able to adequately give to help blow off any CO2 needs and to help give good volumes for the patient. A set rate to let us know how fast we want to give these breaths to the patient. If their acid-base status is much higher, if they're hypercapnic or so, we definitely want to have a higher rate to help blow off that CO2. And also we have our PEEP, that positive expiratory pressure that keeps our alveoli distended to help with oxygenation. These are our set settings by the doctor. We will have these set by the per doctor's orders, and these are the orders here these are the settings that will get changed per doctor's request. It is touchscreen friendly. We are able to touch the screen and move with the knob here and to accommodate those changes that the doctor requests. How we accept, you can do two ways. You can press the touchscreen, or you can accept it by pressing the knob here, and which would then accept the settings that you desire. We have a silence button here that gives us 2 minutes of silence, alarm silence, which will display up here in the right hand side. We do have a O2 button here, which if we press it will give us 100% oxygenation for 2 minutes. This is very important when we want to suction the patient. We want to hyperoxygenate so we don't actually have the risk of them losing their O2 sats while giving a suction. If you press back the O2 button, it'll revert back to the previous FiO2 and our timer is gone. We also have another suction button. On the top right hand corner over here, which says suction, if we press this suction button, it will do the same thing. It will give us 100% oxygen, but that bar will be divided into 3 pieces. Each piece is 2 minutes of oxygenation, giving a total of 6 minutes of pure 100% oxygenation. At this rate, we can do it also for suctioning, but also if we need to turn the patient and bathe them. It's very important that we have them hyperoxygenated if they're at risk of desatting with movement or changing positions or so forth. This will give us just a little bit more time to have them oxygenated while we're doing those tasks. We have a lock button. A lock button will lock the touchscreen here to prevent any touchscreen here and causing some altered settings here, and we can unlock it by pressing that lock button as well. In case you are messing with this, or RT is happen to mess with it and they do their setting changes per doctor's request, if the screen is displaying a screen that is not familiar to the nurse, or you need to figure out how much volumes they're getting or so forth and unable to see that with the current screen being shown, you simply have a home button right here. And this home button is just like a cell phone home button that will take you to the front page. By pressing the home button, it will take you back to the home page, displaying the set settings and displaying the pertinent information that we need to see if the patient is doing well. Now on the ventilator, we have a couple of complications that I will discuss. We tend to come across the most common complication is peak pressures. Now, elevated peak pressures can mean a lot of things. Increased secretions in the patient is waking up and giving inspiratory effort. We have an occlusion or kink in the line causing an obstruction in the airways, or we have water buildup in here due to the condensation because we are providing heated air, and the water will be kind of slushing around in there and we need to drain it. The other thing that we can also see is internally from the patient, we have an elastic resistance, which is the compliance of the patient. If they're in ARDs or they're having very poor compliance in their lungs, very whited out lungs, that will tend to drive up the peak pressures because there is stiffness in the lungs causing higher amount of peak pressures to help ventilate the patient. And we would have to notify the doctor if the patient is fully sedated and they're breathing what the set rate is set on the ventilator, but they're still hitting peak pressures. First, we want to see if we can assess it ourselves, whether the patient has secretions or if it's a compliance issue, or if there's any fluid in any water in the tubing or so forth. If all these pass, there's no secretions, there's no water in the tubing, there's no kinks in it or so, RT has assessed it and they're able to see that it's possibly a compliance issue, we want to tend to notify the doctor to make some possible setting changes. We have another complication that we may run into, and if the patient gets off the ventilator, we'll see the alarm of patient disconnect. Sometimes the patient will be disconnected and we're either popped off on this side, on the inspiratory or the expiratory side, or the heated wire. If the heated wire is disconnected, we will tend to lose our tidal volume and it will indicate that the patient is disconnected. Those are the two most complications that, from a nursing standpoint, that they will encounter: high peak pressures and low tidal volume. When it comes to tracheostomy patients tend to have a low tidal volume issue at that. Due to the fact that their cuff pressures right here in their tracheostomy, having that chronic trach for so long, they're able to bypass, or they're able to be very comfortable with their trach and eat and swallow while being on a ventilator, and the cuff pressure may not be fully inflated, and we may not be reaching those set tidal volume that is set on the settings here. They may be getting good volumes, they're nice and pink, they're oxygenating well, but their volumes are not, their actual volumes read is not meeting the needs of what is set here. So just be mindful and let RT know, or if the patient has a chronic trach, they may be the exception to that. But I would say the most common things to look forward here, the most three values here when it comes to the ventilator, is how the patient's doing peak pressure wise. We don't want to go over 40. Anything over 40 can cause some barrel trauma and can potentially cause any pneumo or tension pneumo. We do have our tidal volumes. We definitely want to be sure that the patient is getting adequate volumes. If whatever is set, the ventilator should be delivering a minimal of what is set and a little bit over if the patient's giving some effort or so. And our respiratory rate. If the patient is waking up from their sedation and they're unable to wean at this time, we definitely want to see if we can get them stable back on sedation, so that way they're not breathing way over the vent. Chances are they could be breathing 20 or 30 breaths per minute, and we definitely need to keep them stable while on the ventilator when it's their time to come off their vent. This ventilator is very sophisticated. We do have a standby button here, in which if we press standby, it will actually put the ventilator on a pause ventilation. We do so by clicking standby, and we will get another warning screen, warning us if we for sure want to put the patient on a standby mode. We then pause the ventilation, and the ventilator is not providing those tidal volumes. It will ring because the patient is still connected to the ET tube, so we want to park it. Once we are parked, we're able to put the ventilator on standby. In case RT is not able to come in for extubation or so, we are able to put if patient is nice and extubated, we can simply press standby, pause ventilation, and park the circuit. And the ventilator is not making any alarms. They're paused, patient is nice and extubated, and RT will come and assess and do what they need to do with the ventilator at that point. Okay.
Let's recap mechanical ventilation. These are some of the alarms we may encounter when taking care of a patient on a ventilator. When troubleshooting any alarm, it is important to start with patient assessment. Begin with work of breathing, lung sounds, pain, sedation, level of consciousness, and medications. High-pressure alarms generally indicate an obstruction in the circuit or decreased lung compliance. To assess for obstruction, assess for accumulation of secretions in the ET tube, kinked tubing, or water accumulation in the circuit from condensation. Also assess the patient for pain and sedation. Ensure the patient is not biting on the ET tube, as this may also be a cause for obstruction. Troubleshooting a high-pressure alarm may require suctioning, adjusting the bite block, removing any kinks in the circuit, increasing sedation, or calling respiratory therapy to adjust settings. If you suspect a mucus plug may be causing the obstruction, call respiratory therapy immediately. A low pressure and/or vent disconnect alarm generally indicates a leak somewhere along the circuit. Assess the patient work of breathing and breath pattern. Hiccups or an ET tube cuff leak may also trigger a low pressure alarm. Possible actions when dealing with a low pressure alarm is to address any patient issues first. Then, look for disconnected tubes along the circuit. Call respiratory therapy to fix or adjust settings. A high tidal volume and/or high minute volume alarm may be triggered by agitation, pain, coughing, or if the patient is fighting the ventilator overall. More concerning reasons for this alarm may be decreased lung compliance. The patient may have extubated or a change in neurological status. If the patient is awake, evaluate for extubation. If these interventions are unsuccessful, call respiratory therapy to assess ET tube placement and notify physician. A low tidal volume and/or low minute volume alarm may indicate an obstruction. Possible causes are kinks in the ET tube or tubing, accumulation of secretions in the ET tube, or a mucus plug. Coughing or decreased non-compliance may also trigger a low tidal volume alarm. To troubleshoot the low tidal volume alarm, suction is needed, look for disconnection or leaks, decrease sedation as needed, and if these interventions are not successful, call respiratory therapy to assess and/or adjust settings. High rate alarms may be triggered with agitation, pain, coughing, or if the patient is fighting the vent. Patients who are more awake or alert may be attempting to breathe over the ventilator. A high rate alarm may also be triggered by a more serious complication, such as change in a neurological status. To troubleshoot the high rate alarm, consider pain medications. Increase sedation if the patient is agitated, and if unsuccessful, call respiratory therapy to assess and/or adjust settings. Notify the physician as needed. Lastly, a low rate and/or apnea alarm may be triggered by oversedation, and more worrisome cause could be neurological changes, where the breathing patterns alternate between periods of hyperventilation and then apnea. To troubleshoot the low rate and/or apnea alarm, decrease sedation. If the patient is still not arousable, stop sedation, call respiratory therapy, perform a neurological exam, and notify the physician.
Next, we're going to discuss rapid response in the COVID-19 patient. How to initiate a rapid response. Dial 59911 to activate the rapid response team on your iMobile phone. You can also push the RRT button on your Responder 5 nurse call button in your patient's room. Who can initiate a rapid response? Any staff member or family member that is concerned for a patient's safety, well-being, or condition. A rapid response should be called for worsening or deteriorating conditions, changes in heart rate or blood pressure, changes in respiratory status, acute significant bleeding, a grand mal seizure, new acute onset of chest pain, and acute mental status changes. Initiating a rapid response for a COVID patient. Ensure all nursing interventions have been attempted prior to activating a rapid response. Remember to elevate the head of bed, reposition your patient, allow patients time to recover after performing ADLs, give your patients at least 10 to 12 minutes to recover. A lot of times simple movements take a lot out of them and exert them, so increase their flow rate on their oxygen devices to give them a little bit more comfort during that recovery stage. Check your O2 tubing connections to ensure the device is working properly and connected. A lot of times during transfers, our tubing can become disconnected from the wall. Notify RT to assist with managing patients' respiratory needs if needed. To review the rapid response protocol more in depth, you can visit My MHS Central and search under your order set library. This concludes our presentation. If you have any questions, please feel free to reach out to your Northeast Methodist Education team.